Hi everyone. Today I'm going to talk to you guys about disorders of the colon and rectum, and we're covering session 1, which is really pathophysiology and diagnostics. My name is Baharak Moshiree. I'm at Atrium Health, which is located in Charlotte, North Carolina, and I'm director of Motility here. So the common diseases of the colon will be covered first. These are diseases and syndromes, I would say. So diverticulosis, we will cover, pretty in depth since this is actually pretty common. Irritable bowel syndrome is also a common disease syndrome that is special to me because it's an area that I do research in. And then inflammatory bowel diseases are also colitis, Crohn's disease. We'll also cover constipation, but not diarrhea syndromes, as this talk is only 20 minutes. Colonic ischemia, infectious colitis, sigmoid, and cecal volvulus can also develop, and then polyps and tumors. So diverticulosis, this is very common. It's often asymptomatic. So patients who have this condition don't have any symptoms. And this, you can see on the colonoscopy photos here where there's these outpouchings in the colon. And what is the cause of this is it develops from what we think is herniation of the colon mucosa and what's beyond the colon mucosa, which is called the submucosa, and defects in a muscle layer in the colon that's within the wall. And this occurs at sites that are penetrating blood vessels in the colon. And again, it's extremely common, and it's usually found just incidentally when we're scoping a patient. And scoping a patient means doing a colonoscopy. And these patients can have, other than just having no symptoms, they can have diarrhea, they can have constipation, bleeding can occur. When bleeding occurs, we call it diverticular bleed. And they have just red blood per rectum. Sometimes it's like dark blood. And if there is pain in patients who have diverticulosis, it's from either spasms or this underlying inflammation that can occur. And then when the diverticula become infected, we call this diverticulitis. And how it's diagnosed is by a CAT scan that shows there's inflammation in the colon. And most of the time, those patients get placed on antibiotics. There are risk factors for diverticulosis. Those are the risk factors are being on a low fiber diet. So, in the United States, Australia, westernized societies with low fiber intake, there's a higher risk. Age is a risk factor. 50% of patients over age 70 will have some kind of diverticulosis. And then obesity, use of non-steroidal medicines like, the over-the-counter formulas like ibuprofen, Advil, all of those can cause it. And then drugs like opiates, which is Crohn's disease. There is some diagnostic testing that's, recommended in patients who have suspected irritable bowel syndrome. And these are really recommended in patients who have more of the IBS with diarrhea. And the most important is to test patients who have irritable bowel syndrome and the diarrhea kind for celiac disease, and that can be done by blood tests. And these are the blood tests that are listed here are IgA tissue transglutaminase and quantitative IgA. We also want patients who have the diarrhea kind of irritable bowel syndrome to have testing with stool tests, specifically for fecal calprotectin and lactoferrin for inflammatory bowel diseases at least once. If they're having a colonoscopy, because they also have other alarm features, such as they're over, we say now actually 45 years of age, blood in the stools, symptoms at night, unintentional weight loss, changes in symptoms, antibiotic use, and a family history of organ disease or organic GI disease, such as inflammatory bowel disease or celiac, that if they're having a colonoscopy, they should have biopsies of the colon so that we make sure that there's not this other thing called microscopic colitis, which is found in 1.5% of patients who have irritable bowel syndrome. The differential diagnosis for constipation, it's very wide. So what can cause constipation could be medications. For example, NSAIDs again, things such as ibuprofen, aspirin, Advil, pancreatic enzymes that patients are on for chronic pancreatitis, possibly, although that's a little bit controversial, opiates or narcotics can cause constipation. Some of the antacids, like Tums, can cause constipation. Even some PPIs can cause constipation. These are frequent drugs that our patients take. Bile acid sequestrants can be constipating, and then drugs such as anticholinergic drugs can constipate. Now, other than drugs, irritable bowel syndrome with constipation makes up 20% of the constipation population. 40% of patients who have pelvic floor dysfunction, you know, are diagnosed as having chronic idiopathic constipation. So we'll talk about that, what that means even. And then 2% of the patients who have constipation have something called slow transit constipation, which is an impairment in how the colon is able to contract and move forward. And we can do diagnostic tests for that. And then there's chronic idiopathic constipation, which the US prevalence is like 12 to 19%. So these are high. The diagnostic evaluation is a rectal exam. So the best way that we have as physicians and caretakers and APPs is to do a rectal exam. So the importance of the rectal exam is that it's, first of all, visual. So we look to make sure there's no what's called rectal fissure. We make sure there's no hemorrhoids, which can result from severe constipation and straining. We make sure there's no rectal prolapse, which is a protrusion of the rectum that comes through the rectum as a result of people straining so much to have a bowel movement. And then we can obviously palpate for mass in the rectum, make sure if we feel hemorrhoids inside that we're treating patients for that. And then testing the muscles and seeing if the patient, when we ask them to do squeezes and push out our finger, are able to coordinate the correct muscles to be able to do that. If we feel really hard cemented stool in the rectum, then that can lead to other diagnostic testing that the patient may need. So the most important diagnostic test is our finger, especially for patients who have constipation predominant IBS. And then I would say also for the mixed type IBS patients, but really every patient should get that at least the first time. Now, for severe constipation, that's the 2% of patients who've tried a relaxative, whether it's over the counter or not, nothing's helping. Colonoscopy is actually just only indicated if you're 45 and up for colon cancer screening. So colonoscopy is not a test that's necessary for constipation, unless the patient has iron deficiency and other stuff going on. Now, there are transit studies that can be done. Those are called whole gut scintigraphy, which is only available in a few centers such as Mayo Clinic. There's SITS marker study. That's a radio-opaque marker study depicted here on an X-ray. Then there's wireless motility capsule, which involves a capsule the patient swallows, and it goes through the entire gut. And we look at both the gastric, the small bowel, and the colon motility to see if we can see good contractions or not throughout. That could be one of the causes of constipation. And then there's manometry, where we actually put a probe inside the rectum and we measure pressures in the rectum. We ask the patient to do certain maneuvers. We ask them to strain. We ask them to squeeze. We ask them to rest during the test. And we check the nerves and muscles and how they're functioning in the rectum. There's also another test called the balloon explosion testing. Then we have MRI defecography, where contrast is placed into the rectum, and we can see if there's what's called a rectal seal, which is an outpouching of the rectum that occurs. You can see it here on evacuation, depicted at the arrow, where there's an outpouching that occurs anteriorly towards the vagina. This back here is the spine. And then we really can look at the anatomy of the rectum and see how is the rectum coming down in the pelvic floor. Is it able to allow the patient to defecate? Then there's acute syndromes in the colon. So these are colonic, what's called pseudo-obstruction, which isn't obstruction, but it looks like it. Obstruction would be a complete narrowing of the colon wall, and that ends in surgery. And then ileus is where the colon just doesn't move. It's almost like a paralyzed colon. It won't move. Usually results because the contents of the small intestine are not able to contract and move forward, or it can occur in the colon. And this is usually due to inflammation from some systemic illness or something else going on. It could happen post-op. And there's an extreme pain that occurs with this. So patients usually have extreme abdominal pain. It comes on suddenly. The abdomen is just very distended, tight. Patient may vomit, and then hopefully it resolves completely. The most common cause of an ileus is either abdominal or retroperitoneal surgery. And this is a common cause of like hospitalizations and what revs up the cost of hospitalizations in the country. It usually resolves in 48 to 72 hours. It's really important for any surgeon that operates on the colon or the abdomen to put patients on a drug that can prevent the effects of an ileus, and those drugs do exist. and also to really limit opiates after surgery, because opiates themselves paralyze the colon and the small bowel and the stomach. So giving too much of them can be problematic. This is Ogilvy. There's actually a syndrome that's named after the surgeon who was actually a war veteran in the Balkans and served in World War I and World War II. And this orthopedic surgeon, also the GI, he was a sailor as well. And he defined this acute massive colon extension that can occur in some patients. Usually they're institutionalized or in nursing homes. And there's a complete extension of especially the right side of the colon, and there's no mechanical cause to this. And usually this is self-limited and hopefully will recover. Otherwise, there is a mortality associated. So the signs are distension. It occurs over 3 to 7 days, very acute, can occur over 24 hours. 80% have, mild to constant pain. There is significant distension usually, sometimes painless. 60% have nausea, vomiting, 50% have symptoms of constipation, and most patients will have good bowel sounds when we listen. But it can also be due to excess dehydration or when the electrolytes like magnesium, phosphorus, potassium in a patient are abnormal. This is what it looks like. So on X-ray, it is this black area is just distension of the colon. It can dilate to like 20 centimeters sometimes. This has a risk of perforation, which is the colon can just pop. And as a result, patients can develop sepsis, and usually patients get really sick. X-ray and CAT scan is the way to diagnose this. And usually the CT scan is better than all the other imaging. This here is a picture, it's a sigmoid and colon volvulus. So you have a sigmoid volvulus over here on the left side, and the colon just is so distended, it's the balloon, it pops like with air. And then here you have a cecal volvulus where it looks like a little kidney bean. Out here where the right side of the colon is just completely distended, it's compressing on the left side of the colon, which is over here. And as a result, these patients are also at risk of having a perforation. And with the sigmoid volvulus, we do a colonoscopy to decompress. With the cecal volvulus, which also develops acutely, these patients usually have to go to surgery to get that part of the colon resolved and removed and untwisted. So just to show another picture, there's actually a disorder called, Chagas disease, which affects the esophagus. There's one called Hirschsprung's disease, which affects the rectum, where the rectum muscles do not relax. And as a result, patients develop what's called megacolon. And these conditions are all due to these pacemaker cells being lost and deficient. And things that can attack the pacemaker cells in the gut are things like viruses, for example, COVID-19. Other infections can affect the pacemaker cells. And these pacemaker cells go from esophagus all the way down to the colon. And they are located in where the nerves in the gut are. So they're located in what's called the myenteric plexus and the submucosal plexes. And they're also within the muscle layers. And so this is what promotes movement of the gut and helps motility of the gut. So I thought it'd be good for you guys to see the picture of that. And if those don't work, then you get these other conditions that we're talking about here. So this is a SITS marker study where we ask patients to, again, swallow a capsule, and then it breaks up into 24 pieces, and we count how many of these are left after 5 days of ingestion. And we look for these clearance to see if there's a portion of the gut in the colon that's not working, and if they're abnormal, it could be that there's slow transit constipation or the pelvic floor is not allowing relaxation. So when we diagnose patients with dyssynergic defecation, we use this 50 ml watermill balloon, and it's depicted here. And that goes in, it has polyethylene catheter that's attached. We go past the puborectalis muscle that goes around like the sling around the rectum that allows us to have continence so we don't poop on ourselves. And then we see if the patient is able to expel this 50 cc balloon in the 2 minutes they're given. The patient sits on a commode, and that's one way that we can test and see if the patient has dyssynergic defecation. Now, this has to be complementary with another test. So usually for the other test, we use what's called the anorectal manometry. And that test is done in dedicated motility centers and done by some colorectal surgeons around the country who operate on the colon. And this test also helps us determine if the patient has this problem. So here we have the picture of the coccyx bone and the back, and the rectum is depicted here with this angle. And so normal physiology, when the patient is straining to have a bowel movement, what should happen is that that angle needs to straighten up more during that straining. And as the angle of the rectum straightens, the pubotalus muscle relaxes, and that allows stool to pass. So when we don't want normally patients to push so hard, because if they push and strain a lot, they get hemorrhoids, they can get fissures, and they may not actually be able to coordinate the muscles correctly to be able to push it out. Hemorrhoids are pretty common. 40% can cause bleeding. There's a lot of swelling that's involved. Some of them itch. It's in 24%. And then pain does not occur in hemorrhoids unless they are what's called thrombosed, which means the blood supply to the hemorrhoid is cut off. So those are the painful ones. And if a patient has pain, that should prompt evaluation for some other cause that's coexisting with their hemorrhoids. So again, 50% of patients have hemorrhoids by the time they're 50. 10 to 20 million people have active symptoms, and then 5 million patients seek, attention every year for this. We spend a lot of money on over-the-counter medications, and most of the colonoscopies, that we do on an inpatient setting, are done due to bleeding from diverticulosis and hemorrhoids. So these are really common, and then most are just treated with relief formulations that are over the counter, and then steroids. So this is the anatomy of the hemorrhoids. So you can see the internal ones are inside and past the dentate line, and then you have the external ones that are more outside, and if they get thrombosed, they're extremely painful. The risk factors for hemorrhoids, so lack of fiber and fluid intake has been a potential risk factor. Sitting too long on anything, even at a desk, like we've been doing during COVID with virtual interviews and everything, can be a cause. Sitting too much on the toilet, straining too hard, ignoring the urge to defecate can be all problems. Patients who have connective tissue diseases like scleroderma, lupus, Ehlers-Danlos have increased risk of hemorrhoids. And then any condition that increases the rectal tone can also cause it, anxiety, etc. So it's usually due to the enlargement happens because of the weakened muscle and the elevated sphincter, which is the muscle in the rectum tone, and then an increase in abdominal pressure. We diagnose hemorrhoids by visually inspecting them. We also, of course, the rectal exam can be helpful because you can palpate it. Anoscopy is the way that we can look at the anus area, and usually it's done by a GI doctor or surgeon. And then flexible sigmoidoscopy is where we use a colonoscope and we go up the rectum and the colon, and we're able to see in backwards view of the rectum and in forward view whether a patient has a hemorrhoid. So in any patient that has a hemorrhoid, we also have to consider what if they have this pelvic floor dyssynergia, which is, again, so common in patients with constipation. They could have what's called the anal spasm that's causing a fissure. We'll talk about proctalgia fugax and what that is. And then, of course, an abscess in the rectum, which is an infection around the rectal area, can cause problems, and especially that's seen in patients who have Crohn's disease. So anal fissures, it's almost like a paper cut of the rectum. The rectum has a lot of nerve supply, and it can be extremely painful to have these rectal fissures. So these are patients that have either acute or chronic pain. 90% of them are located posteriorly, so towards the spine. Any trauma, like a hard stool, sexual practices can cause fissures. Inflammatory bowel disease patients, especially Crohn's patients, have a higher risk. We have to make sure there's not cancer infiltrating, but most of them are not related to any cancer. They can happen post-op, and then infection is it. Moving on to fecal incontinence. So this is fecal leakage. There are structural reasons why patients would have fecal incontinence. There's stool characteristics that may be a reason, such as even having hard stools, and then functional abnormalities that can cause it. Fecal incontinence is highly prevalent. It's seen in 90% of the population, and it's actually common both in men and women. In women, it's 9%, and in men, it's actually 7%. And in people who are over 70 years of age, it's 17% is the prevalence. So it is very, very high. We do have diagnostic testing for fecal incontinence. That's done with, again, an anorectal manometry to see if the sphincter pressure, the nerves are okay. There's ultrasound that can show if there's a defect in the rectum. For example, a woman who had a vaginal pregnancy maybe 30 years ago and had an episiotomy would be at risk. And then there's testing that we can do with EMG, which is done to distinguish whether there's a nerve or muscle problem, and those kind of have fair evidence behind them. So the summary of all the diagnostic testing we have, you know, there's functional assessments with the anorectal manometry that's done with this probe and catheter. There's ultrasound to see if the sphincter muscles are intact. There's defecography. This is fairly new, but it's kind of a nice way of evaluating. The MRI is new. There's also barium defecography to see if there is an evacuation disorder, if there's a structural problem, for example. Sometimes the bladder is falling down and is putting pressure on the rectum, and that's the cause of patient symptoms. There's EMG, which is done when patients go through physical therapy, which is very effective for a lot of these pelvic floor disorders. Then there's pudendal nerve motor latency, which we didn't talk about, which is a way to assess the sacral nerve function, especially in diabetics. And then there's new stuff like this little depiction here that looks like a wine glass that's flip, but for the rectum, where we actually evaluate if the rectum is able to distend adequately. Some patients have poor compliance and the rectum is not able to distend appropriately. So then there's polyps, right? So of course, you know, this is not a talk on colon cancer screening, but it's really important to get some kind of colon cancer screening, whether it's a colonoscopy, virtual CT colonoscopy, fecal DNA testing. It's important in patients who are age 45 and up, and those who have risk factors or family history of colon cancer. You know, April was Colon Cancer Awareness Month, just like it was IBS Awareness Month, and it is really important to be cognizant of getting screening tests done. So polyps can develop into cancer, and colonoscopies save lives. Now, for the functional rectal pain syndromes, this is proctalgia fugax and levator ani syndrome that we'll talk about. Levator ani syndrome happens more in women. They're usually younger women. It's a rectal pain that's intense. It's can happen intermittently for 2 weeks, and it can last over 20 minutes at times. It's vague, dull type of pain. It doesn't awaken the patient at night most of the time, and it worsens when the patient is sitting or defecating. And usually walking and lying down helps it. So this muscle that's in the rectum kind of spasms, and that can be very painful. Then there's something called proctalgia fugax that happens in young men, really type A personalities, high-performing folks can have this. It's a sharp stab-like pain, so this is very painful, as opposed to like an ache that happens with levator ani. Wakes up the patient. It's usually induced by stress, where the patient just kind of tightens their sphincter all the time, and it's a smooth muscle dysfunction, and patients who have IBS can also have it. Anorectal manometry, which is depicted here, is the way we diagnose it. So we test patients' squeeze, we test their muscle control, we test their relaxation, and all of that in a color topography as we depict here helps us determine whether patients have these conditions that we talked about. So lastly, happy birthday, 30th birthday to IFFGD. You're 16 years younger than me. So, you know, still in your youth, and I'm sure you'll have fantastic accomplishments as the years will roll on. And I'm excited to be working with you guys on several projects that this great team of ladies and gentlemen, but a lot of ladies have really formed. So it's great to have you guys really advocate for our patients. Thank you so much.